And we now have the person arriving, in fact, the family arriving of a number of people, and we have the administration team, the nursing team, and the doctors all ready. And so now we're going to hear what happens with the nursing assessment.
Hi everyone, better night tonight to come out than going to play a game of football, hey? So I'm going to talk to you about the nursing assessment component of the health provision of newly arrived people with a refugee background. And I also need to learn how to drive this. So just a brief overview of what I'm going to cover tonight, just some key considerations for undertaking the nursing health assessment. Some health assessment with a refugee focus, because things won't change regardless of who you're assessing, but there's some other things that you need to think about. We'll touch on some immunisation catch-up, some routine referrals, some mental health self-care for yourself and your team, and nursing professional support. So in our considerations, we have diverse populations coming through our refugee services and through our general practices. How do we get to understand everyone's needs within that cultural space is probably impossible. So we need to be really aware of how to ask the right questions, apologise when we make mistakes, but it's about don't ever assume anything, because what may be appropriate for one person from this an ethnic group may not be the same for the person from the same ethnic group the next day. We need to really flag that we can't do our job without professional interpreters, and for all of us as health professionals, we actually need to work in scope of practice under our standards of care. We need to figure out where people have come from, and like this, our case study family tonight have come from a camp. So go on YouTube, that refugee camp, before they arrive, and get a look at what that camp looks like, because it will help you understand their lived experience, and in case this family for 10 years. And camps are quite different, so it's really important to get that visual picture. We also need to consider literacy and education that they may or may not have had. I mentioned interpreters, and we're going to have that theme come up across tonight's presentation. Need to think about how you maintain that confidentiality, the health literacy of the interpreter, the gender. We also need to know about ethnicity of that interpreter. Is it the same as the ethnicity of your patient? Really important to understand that. And the intergenerational issues around interpreters. Young interpreters asking older members of the community taboo questions that you'll never get an answer from. The benefits of on-site versus phone interpreters and the challenges around both. And then consider around cultural events that are happening within that person's community at the time. And at the moment we're currently in Ramadan. So just being mindful of how you set up that encounter with the family or your patient. And any other customs, considering getting permission to touch someone's head when you're doing their height, for example, may be really important. So in that nursing assessment that we're specifically looking at things that you would normally look for as your next of kin, but also you're looking for your support network this family may have arrived with. You want to know about the caseworker details, very important, because even though their role isn't to be bringing the patient to and from your practice all the time, they're definitely a point of go-to when you're having challenges with engaging with your patients to come back. You want to know about all the languages that they speak and read. That makes a difference in some of the resources that you may provide. So you want to know about their literacy in their first primary language, what educational level that they achieved if they went to school. And that may change across refugee camps as well as non-refugee camp clients, patients. You want to know about their health literacy from where they've come, because that will help understand what you need to be talking about from a health literacy in Australia. Also, you want to know about work history. Our patients come from no work history to PhD students who are published in the BMJ. So we need to be really mindful that this diversity is there and how we actually pitch our conversation, our interview, and what information is really important for the patient in front of you. And as Margaret has talked about, pre-departure screening and assessment and any health undertaking and alerts. one of the great things about having a family come to your practice is we get to see the whole family, and that doesn't always happen in general. The rest of our other people that we see on a regular basis. So you get the chance to assess the family and the dynamics. How does a family interact? Is there any gender issues or red flags that you're seeing that may be cause for concern in the future? How does mum and dad bond with the children? Is that working or is it not? And in this case where we've got mum who's got 4 children and about to have another one, is she the sole carer of those children? What does that really mean that we need to be looking at for ongoing care? We want to look at how behaviour management works in that family dynamics. Is it going to actually be appropriate for the laws and legislations in Australia? And it leads into other things around child safety and domestic violence. And we need to be flagging those early so that our families don't end up getting into trouble, because often it's education is the key to preventing those critical events happening. I think the genogram is probably the key assessment tool that opens up conversations. You want to know where things happen, when they happen, what happened to who. You want to know who's alive, who's not here today. Has anyone in the family been left behind? And in some of our cases, we've had babies being left behind because they weren't on a visa. So mum presents lactating with a baby that's been left with someone, absolutely dire situation. But you need to know ask those questions. You want to know about the past family history as well, and Margaret will go into more of that. The main thing is today, what are the priorities of this family? Because they come to you with maybe not an expectation. Our family from the camp, for example, may not know what to ask for. So we need to really be mindful of what do you expect today, and try to support that expectation being achieved, because it's about building trust. And if we don't build the right trust, we're not going to actually progress an effective health outcome for the people, and they won't necessarily come back to their practice. So looking through those routine health issues, existing health issues, you want to find out about allergies. Most of our families need to be explained what an allergy is. They don't actually know. And then you need to tell them, think about, why do we ask allergies every time we see them? Because it's not about that we forget or we don't write it down. It's because we need to check every time in case something's changed. And that's definitely a comment that I've received in the past. Just some of those routine things there that we would normally do. But the main thing to pull out of that is, what's the knowledge of their health illness issues? What have they done in the past? And what are their expectations of care? Now, I've had a gentleman in front of me sweating quite profusely, poor vision, kidney pain and peripheral neuropathy, who got on the plane to Australia and decided that his insulin-dependent diabetes was going to be cured in Australia, and he stopped taking his insulin. So, you need to be thinking that what's outside the square, what do people have come to Australia with assumptions, because they're definitely not what we'd be thinking. Specific health areas. Here we've got, in this family, we've got mum who's pregnant, needing to be linked to make sure antenatal care is organised very quickly, and having some orientation to how deliveries occur in Australia. So that's a really complex, sometimes at that time in advanced stage of pregnancy, and each area around the Queensland will have a different referral pathway and different support services in place. So planning on that delivery. The men's health, really important to check in with men. I've had a gentleman who disclosed that he had incontinence, and he started crying. And I said, why are you crying? Are you in pain? And he said, no, I'm unclean. And I said, well, what does that mean for you? And he said, well, I can't go to mosque. So his priority had multiple other health issues and comorbidities, but his priority was actually to manage his continence better so that he could actually practice his faith. So we need to really pull out those really important things. What's your priority today? And for our young people and children, if the parents aren't ready to talk about anything, they're definitely not ready to talk about their children's needs. So once again, that health assessment is about building trust, You may not get the information today, it may be next time or the time after. Sometimes the first occurrence is a bit like an onion peel, where you get the first episode is taking that dry, scaly bit off, building some trust, and every time they come back, you get to take another layer off until eventually you unpack the real priorities for that individual or that family. So really observing how people interact, what they look like, look at for scarring. Often you'll find out what's really happened around injuries as well as trauma and torture, and that may bring something out. You need to be prepared and ready for those stories though, and be able to provide the time if you actually do trigger off a traumatic story. Looking for all those rashes, tinea capitis, how people move, have they been injured so much during trauma and torture that they've got disabilities around that, and any issues around growth delay. I'm just going to talk about pain here because it's insidious in many of our families that arrive, and it's multidimensional, and you may have someone who's got pain in all parts of their body. We need to accept that descriptor, and over time you'll find out where that pain sits, and may need some other referral pathways, including to our torture trauma counselling team. Constipation, a really big issue, and I'm sure Margaret will touch on that as well. Some of the nutrition diet questions that you may think about is, do you have an appetite? What do you feel hungry? There's lots of things happening at the moment, so priority may not be eating food or even drinking water. And this family from a refugee camp has probably only had bottled water out of their filtration facility. So when they turn up in Australia, are they drinking water out of the tap, or are they wasting lots of money buying bottled water? So you need to be checking on that. Really important to ask about how often you have meals. This becomes really essential when you're providing ongoing care and medication. If your patient in front of you is having one meal a day and you're prescribing TDS medications to be taken with food, we need to be able to know what that looks like, how do we actually enable them to be compliant with the regime to actually make them better. Fruit and vegetable intake prior to arrival gives us a bit of an indication of the nutrients they may or may not have had access to. We want to make sure that they're now able to access culturally appropriate food, and our case managers and settlement services provide a fabulous service in doing that, but sometimes it doesn't always work, or people don't feel it's appropriate even if they have been linked. The other thing to think about is food affordability now. So are the family using the money that's coming from Centrelink appropriately to make sure that they do have food? Are they sending money back to provide support for family left behind? And my experience when this has happened, we've worked with our settlement agency to provide some support around financial planning, budgeting, to try and support them in their decision making around where they spend their money. And for people who have been here just a little bit longer, you may find that they might end up gambling because they actually get caught up in trying to find money to bring other people here. So just be aware that that may be sitting in the back. Okay, good. Rest and sleep. Really important to think about all of those energy levels. If you've just got a recently arrived family, their world's upside down, are they sleeping? Are they able to concentrate? Can they remember things? And in this case, our family, is mum actually sleeping? She's 30 weeks pregnant, she's got 4 little children. Is she getting rest? Is she having a nap during the day? Is dad helping out with the care of the children? And with his already flagged torture trauma issues, is he actually getting some rest as well? Who else can you bring into this conversation? Is there family here to help? We've had families where we've asked, are you feeling safe here? Is anything that made you feel scared? It's really important to assess for that. It may be that the school had fireworks the day before on a Friday night and they turn up to your practice and they're terrified because they thought bombs were going off in their suburb. So you don't, things that we take for granted, really put that lens on your questions. We had one family who had rocks thrown on their roof, and they were absolutely terrified of who was coming through the door. So again, working with our settlement agencies to provide some support so they can then talk with the policing teams around how to support them in a better way. I've put medication in here as something to consider for the whole practice, really assessing for traditional medicines, traditional healers. They may be really important in enabling better outcomes for the modern medicine treatment plan. So factor that into your interview. Check what they know about medication they've had in the past, and how did they take that? Did they share the medication? Were they compliant? What were the barriers? And when you prescribe medication to a new person here in Australia, how do you know if they're going to get the script made up? How do you know that they know how to go to the chemist and pay for it? Do they know they have to pay for it? Because often our chemists have the scripts are filled at the back of the pharmacy and you pay at the front. And I've been with a gentleman who was given the medication, and so he thought he didn't have to pay. So we went to walk out the front door of the chemist, and I was able to say, no, you've got to go this way, because there was a security guard at the chemist and he would have been picked up as potentially trying to steal. And what a disastrous outcome for him, being fairly newly here in Australia, not to know how to do that. So once you prescribe medication, think about how, as a nurse, you need to make sure that your patient comes back and someone explains to them, this is your medication, when you take it, how's it stored, date and time, and not to share it, and what to do once it's finished. Is this the last course, or do you need to come back and have further follow-up? Immunisation catch-up now in Australia. For those people at 10 years and older, there's some standard funded vaccines, and that's fabulous to see that in a new budget. So we give immunisation catch-up on the National Immunisation Program as per normal. And for those over 10 years, you can see the little flyer there. That's one of the resources located on Refugee Network Queensland, providing advice around people are eligible for 2 MMR, 3 polio, 3 Hep B, and Boostrix, and 2 ADT. So for you in the practice, making sure that you are ordering that vaccine. The challenges sometimes around getting that in a timely way are definitely still there, work in progress. And the main thing to make sure that all your vaccines are then transmitted to air, regardless of age. And if your patients actually, for some reason, chose to buy a vaccine, make sure all your private stock is also submitted to air. Where you're lucky enough to have families that turn up with records in English, then it's just a straightforward catch-up and complete. Once you acknowledge a catch-up is started, remember that you've got 6 months to finish that catch-up, otherwise Centrelink payments will be cut. That's of recent time changes. If you've got immunisation records that aren't in English, TAFEs will normally translate that immunisation record, so it will take some time, so it may need some extra, nurse may need to be monitoring that fairly closely, because once you get to about day 50 after arrival and you haven't started catch-up, there's not too many days before Centrelink payments start to be in threat of being cancelled. So looking at some routine referral pathways, every person needs to be referred to TB, and Margaret will talk more about that. Everyone who arrives is eligible for free oral health within the first 12 months of arrival, and that's based on a healthcare card. And each area around the state will have a different referral pathway, and if you haven't figured that out yet, please make contact with your local oral health service to see how that works for you. We also recommend that all children, eligible children in your local area, also have a child health referral. This means that developmental milestones can be assessed, there can be appropriate time given to that assessment, advice around sleeping, eating, babies on formula, support here in Australia. And in this case, our case study family, we've got 2 children under 6, so the 5-year-old would be undertaking a pre-school assessment and mum's going to have another baby soon. So you want her to have that referral pathway linked in prior to bub arriving, so that it just becomes part of their health literacy, understanding what's normal here in Australia. I wanted to put pathology taking here in as really important to consider as well. It's really important if you're the nurse in the practice and someone's got a script, doctor's written a request for pathology, that you may need to be able to reinforce the explanation of why that's happening. For many African families, we often also have to tell them why so much blood is being taken, and some other places around the world. I've had patients say to me, "Oh, are you selling my blood because so much has been collected?" So it's really important to unpack that story as well, and to also tell them that just because these blood tests are being done, it's not about that you've been totally assessed for everything that we test for in Australia. We also may need to assist them to get to pathology if a practice does not have on-site pathology collection. Pathology collectors are also funded for tests, but I'm not quite sure if that's being accessed really well. The other important thing is when to come back once the pathology's been done, and Claire will talk a little bit more about that around organising that next appointment. And the same goes for radiology, really having to make the appointment for your patient. They're not going to navigate the environment. They need to know, is this going to be bulk billed or is there a co-payment required? Do they understand the procedure that's happening and any preps that are required? And do they know how to be on time to deliver that, a time to actually take those preps? And then what to know afterwards. So the nurse is a really key person in your practice to help that conversation and making sure that your patient actually gets that test and then comes back. Optometry around the state, as far as access to interpreters, they're not funded, as well as many of our private allied health. This includes the subsidised spectacle scheme. So my recommendation is that everyone should have a baseline vision test. Now, others may disagree with me, but every person that comes to Australia will either be going to school eventually or they'll be going to TAFE. Now, we've just had this week story about an female adult who had been here more than 6 months, and the settlement workers were really concerned about her because she still couldn't remember how to get home, and she was getting lost wherever she went, and she was doing some inappropriate things that really looked like probably maybe there was a mental health referral required for her. But one of the settlement workers thought, let's just go and get your eyes tested. So this lady had no idea that she had a vision problem because her vision problems had been with her all life, and instead of glasses totally changed her view on the world, and it wasn't a mental health problem that she had, it was a vision problem. So think about your referral pathways. It is really challenging without interpreters, but I know collectively that there's some potential to flag that through our clinical advisory group and our partnership advisory group as something that we need to progress. And especially for those who are needing glasses, we need the interpreters for them to make sure that they're actually assessing them appropriately. So winding up very closely now is mental health self-care. This is something really passionate to me. We need to be thinking about ourselves, our peers, our team. How do we look after ourselves when we're hearing and being part of people's lives that have experienced torture, trauma? We're also seeing on the TV daily images that are really confronting from where people have come, and how do we manage that? So I want to challenge you to normalise emotional well-being, because if we don't do that in our workforce, how do we do that for our patients? So some things to think about, and these are things that are part of our team. We have individual responsibility, but we also have team responsibility to look after each other, and we do a "Are you okay?" check morning and afternoon. It's standard practice. And then we might know what's going to happen if someone says no. What if you're going to do when you go home tonight at 2 o'clock and you're still lying in bed and the images are going through your head? So we need to have a bit of a plan of people, support systems, where you go to get that support. Part of that may be your peers. It may be people in your team, but it may be more clinical supervision. or it may be other support services. So people working in Queensland Health, for example, have employment support agencies. For nurses now nationally this year, there's a nurse and midwifery support service, and I've provided the contact details and the web link there. 24/7 you can access that support. So please recognise that we work in a challenging space, and sometimes that impacts on our own emotional wellbeing. And just to flag, the last slide really was around that professional support for nurses who are working with people with a refugee background, regardless of where you work, whether you're in general practice, you're in refugee health services, you might be in a detention centre. Refugee Nurses Australia is a free professional support network. We hold regular webinars. We provide our meetings can be accessed by phone, tablet or a computer. And this is some of the activities that we're currently doing. And we have our first national forum in October in Sydney, where we're starting to write some competency frameworks around refugee nurses and their area of expertise. And that's my contact.